Now, this is a very interesting ECG. You can simply pause the video and you can try to find out what is the problem in these three ECGs. Now, these three ECGs are of same patient. The patient is same. So the ECGs are done over a period of few hours. So first ECG, when we see that we must know this lead is lead 1, lead 2, lead 3, and this is AVR, AVL, AVF, V1, V2. When we see that in lead 2, 3 and AVF, these are called consecutive leads. Now we must know what do you mean by consecutive leads. Consecutive leads are the three leads which usually suggest a particular arterial territorial supply. For example, lead 2, 3, AVF. These indicate the inferior wall, the posterior wall, and this is supplied by RCA, that is right coronary artery. Lead A1, AVL, V5, V6, these suggest lateral wall, and this is supplied by usually LCX artery. Lead V1 to V4 is called anterior wall, and it is supplied by, that is, left anterior descending artery. So in short, these are called the consecutive leads. Now we must know, to call it as heart attack or MI, patient must have ST elevation in more than two consecutive leads. In any more than two consecutive leads. If it is chest leads means lead V1 to V6, and limb leads means other six leads. So in chest leads it has to be more than 2 mm. In limb lead it has to be at least more than 1 mm. So these are the basically criteria to call it as STEMI, uh, ST elevation MI. In here, what we can see that this is lead 2, 3 and AVF. Here we can very nicely make out that this is the running baseline, and there is pretty good ST elevation of at least 4 mm. So there is 1, 2, 3, 4. In here, as we know, this is ST elevation, so we can very clearly see 1, 2, 3, 4, at least 4 to 5 mm of ST elevation is there, and that too in lead 2, lead 3 and lead AVF. So this is basically inferior wall MI. Apart from that, we can very commonly say that we can always have a reciprocal changes. So here we are having ST elevation. In the reciprocal or opposite wall, we'll have ST depression, which we can see in lead V1, V2, V3, V4, V5. So you can see that there is very good ST depression. So there is ST depression of almost 3 to 4 mm. In here V4 also we can see the ST depression. So when there is ST depression along with ST elevation, it is 100% ST elevation MI. Even in absence of reciprocal changes, if there is ST elevation in more than two consecutive leads, then we if it is more than 2 mm in chest leads, and in limb leads it has to be more than 1 mm. Here it is more than 4 to 5, so this is inferior wall MI. So I want to show one interesting thing, that in inferior wall MI, the culprit artery is RCA, and in RCA is the same artery which supply SA node, that is the pacemaker node, and which also supply AV node. So what is the problem is, whenever it supplies, whenever the blood flow to the sinus atrial node is damaged or reduced, patient may develop bradycardia. Patient may have bradycardia, and there may not be any P wave. Second thing, whenever there is AV nodal block, or whenever there is AV nodal artery supply damage, then it can very commonly cause first degree heart block, it can cause second degree heart block, or it can also cause complete heart block. So patients presenting with MI and complete heart block is extremely common. Most of the time, doing thrombolysis or PCI, that is primary coronary angioplasty, can resolve the complete heart block immediately over a period of 20 minutes, 30 minutes, 40 minutes, and patient may not need pacemaker, temporary pacemaking. But if there is significant damage, then patient may need temporary, as patient may need permanent pacemaking as well. Here, what I want to show is, if you can see This is the QRS and this is the P wave. So you can see that in between this PR segment, this PR is all four small boxes. So we tell that if it is more than five small boxes or more than 0.20 seconds, we call it as prolonged PR. And prolonged PR without drop in QRS is called first degree heart block. So if the PR is prolonged but there is no QRS drop, then we call it as first degree heart block. When PR is prolonged and if it keep on getting prolonged and there is drop in QRS, then we call it as Mobitz 1 heart block. Mobitz 1 heart block. So for that, the PR should keep on getting prolonged and there should be drop in QRS. So if there is no drop in QRS and only PR is prolonged, we call it as first degree heart block, and it occurs because this AV node is supplied by this RCA in 90% of the patients. So in inferior wall, RCA is damaged, RCA is blocked. That is the reason why AV nodes doesn't get supplied. That is the reason why patient may develop first degree as well as complete heart block. So in here, what we can see that this PR is normal. That is, it is less than 0.2 to 20 seconds. But look here, look in this second ECG. See here, this PR is more than 0.20. This is the whole small box, the whole large box is there, means it is 0.20 second. Plus there are almost three small boxes, 1, 2, and 3. So it is almost 0.12. So the PR is almost 0.32 seconds. Means this is first degree heart block because each and every P is followed by QRS. Each and every P is followed by QRS. So there is no any P wave which is not followed by QRS. Each and every P wave is followed by QRS. It means there is only prolongation of PR, but there is no drop in QRS. So this is first degree heart block, which we can very clearly see that here also the P and R distance is more than 0.20 seconds. Here also it is more than 0.20 seconds. So PR more than 0.20 second is first degree heart block. So this is inferior wall MI patient presenting with. Here the MI had worsened and now it had started to damage the AV node, and where the thrombolysis was done in this particular patient outside, and we have now this rhythm. Now what is this rhythm? If you can analyze, there is no P wave which is very well visible. So there is no a very good P wave before QRS is visible. You can see there is no P wave prior to QRS. Now that is a different thing, that here it is a P wave. The embedded is P wave in the QRS. Here you can see this is an embedded P wave. Here it is embedded P wave. This is embedded P wave. These are all embedded P waves. So in here, the P wave is not before QRS. The second thing is when you see the width of QRS, see this is the width of QRS. The QRS is very narrow. The QRS is hardly of two small boxes, because the QRS, normal QRS length should be 0.1 second, means around 2.5 small boxes. If the QRS is more than 3 boxes, we call it as that QRS is wide. The QRS is wide. In here, what we can see is here the QRS is very sharp. Here the QRS is very sharp. It is hardly one or two small boxes. And here also we can see that QRS is pretty narrow. The QRS is very narrow. Here you can see that the QRS is very narrow. But what has happened here, that QRS is pretty wide. We can calculate here in this that there is one small box, 2 and 3. So 1, 2 and 3. Almost around 3.5 small boxes are there. It means this is a wide QRS. So there is no P wave and the QRS is wide, And when we calculate the heart rate, it can be simply calculated by 300 divided by number of large squares. So it is one large square, second large square, and this is half and this is half, so around three large squares. So the heart rate is around 100. So there is no P wave, the QRS is wide, and the heart rate is around 100. And this is after thrombolysis of an inferior wall MI, and that comes to one and only one rhythm, that is idiopathic atrioventricular rhythm. What is idiopathic atrioventricular rhythm? Is the rhythm which has heart rate of around 60 to 100. It looks like a ventricular rhythm. So actually the ventricular rhythm should be a kind of bradycardia, because ventricular pacemaking is around, ventricular pacemaker heart rate is around 40, less than 40. But here in case the heart rate is around 100. So it looks like a ventricular rhythm, but the heart rate is in between 60 to 90. It has no P wave. The heart rate is between 60 to 100, and it is typically after MI thrombolysis. It is called a reperfusion rhythm or reperfusion ECG strip, and this is typically idiopathic atrioventricular rhythm. You don't have to do anything to this. This is one of the indication of successful thrombolysis, and patients are most of the time totally asymptomatic. You don't have to do anything. You simply have to wait and watch till the patient gets better. If the patient gets unstable, like if patient lands up in VT, VFib, then it may need treatment. But for this particular rhythm, if the patient is stable or symptomatic, you don't have to do anything. So this is a very nice ECG with inferior wall MI, showing first degree heart block, and also showing idiopathic atrioventricular rhythm after thrombolysis, which suggests successful thrombolysis. This is one of the uh, indication of successful thrombolysis. And that's all. Thank you.